Thank you very much, Richard, and I would like to thank International PI Network for inviting me to be part of the Cochrane Learning live webinar series. Good evening, everyone, or good afternoon, and good morning. So my talk will focus on a work we did using JLA method. It is on women's genital prolapse and incontinence priority setting partnership, which was which has been done in Gondar, Ethiopia. Next slide. So, where is Gondar? It is found at the north west of the country. It is in Amhara region. It is like 727 kilometers away from the capital. Addis basically was the previous capital of Ethiopia, and it is known for its many tourist site attraction. You can see a picture in Fasilides Castle with JLA advisor Toto and one of our partner from Exeter University, Ima. And you can see different indigenous animals if you come to the site, Walia, Chalada, Baboon, and this part of the country is known with by its nice music and dance. You can see the women dancing. Next slide. So when did Gondar Pespi came to picture? I mean, okay, this is about Gondar Pespi. It focuses on uncertainty relating to genital prolapse and incontinence treatment, care, support, and diagnosis, as well as the cause and the prognosis. Next slide. So how and why this PESP came to picture and develop? So it came to picture while I had a visit to a University of Leicester to Professor Tincello. It was in 2018 to do my urogynecology fellowship there. So while we were discussing, we were talking about this problem as a major public health problem. So why don't we implement priority setting partnership using the JLA method? Because there were no any experience during that time in this part of the world doing priority setting partnership, especially using the JLA method. So we preferred it because JLA, the method, it gives a good solution by putting patients, carriers, and other stakeholders equally at the center. Next slide. So the objective of this PESB was to bring patients, carriers, clinicians, and other all stakeholders in together to identify and answer the questions related with prolapse and incontinence. Then by doing that, they will come up with agreed top 10 lists of uncertainties for research. And that will be publicized and the result will be disseminated to the funder as well as to the researchers. Next slide. So the method we used, as I have mentioned, JLA method, which is a good method to put patients, carriers, and clinicians and other stakeholders together by putting some novel way of fitting to the new context. So the JLA method, it has 7 steps. The first one is creating steering group of patient, carrier, clinicians, and other stakeholders working or related with the situation. Then we gather evidences from patients, carriers, and clinicians. The gathered uncertainties will be summarized at the phase 3. Then we will go to evidence check. After we dropped out those which have already investigated and evidenced, we go with the rest to interim priority setting. Then finally, we will decide on the top 10 the priorities using face-to-face workshop. Then will be published and disseminated to researchers and funders. Our PACP has gone through step up 1, 2, 3, 4, and 5. The last 2 steps are not yet done. Next slide. So this is the first step we was conducted in 2019. That is the first steering group member meeting. So the steering group meeting, as it is recommended by JLA, led by a JLA advisor, so that neutrality, transparency, and adherence to the JLA process can be ensured. But as you can guess, it is very difficult for the JLA advisor to follow this process closely from the ground. So then it will be, it became the responsibility of the PACP lead and research associate. As much as possible, the lead and the research associate, they were trying to be neutral and transparent and adhere to the JLA process. Next slide. So on the first step, formation of steering group, balanced representation was tried to happen. So we brought all groups all together. The patients were represented at the different, because we talked to this priority setting partnership, the pelvic prolapse and urinary incontinence. So we had patients who had or have urinary incontinence, pelvic organ prolapse, and we had also carriers for these patients. We had partners working on this area, and we had also clinicians. That means urogynecologists. We had midwives. We had nurses. We had physiotherapists. We had all these stakeholders in as a member of steering group. On the first steering group meeting, we said the name of the project, and the name of the project was genital PACP on genital prolapse and urinary incontinence. We agreed on the term of reference. We agreed on the protocol, and we discussed how we can identify patients, carriers, and other stakeholders working on this issue. We drafted the questions for the initial survey. and we also obtained a consent to have the picture of the steering group member to promote the Gondar PSP project. Next slide. Then COVID came, and there were also war in the region. So, though the ideal time to, the classical time to complete PSP project is 12 to 8 months, and to do the first survey within 2 to 3 months. This one didn't happen, so we waited until COVID had gone and the war is over. So it was reinitiated in 2000 at the end of 2022. Next. So since the JLA advisor cannot, monitor from the ground, of course, she was attending it virtually, but since because of the language barrier, was not like the other PSP. So then the role of the lead and the coordinator also, in addition to working effectively with all steering group members and making sure that the steering group follow the JLA priority setting methods, they had also the role to play like JLA advisor. And they had also the responsibility to look after all the data from the PSP process. Next slide. So once we agreed on the drafts of question, how to we collect uncertainties and identified the patient's carrier and other stakeholder, we worked it again and again on the survey question to mature it. And the survey question had demographic information, and it had category for reason for having a genital prolapse, for having incontinence, and uncertainties related with diagnosis, and uncertainty related with treatment, and the impact of genital prolapse and incontinence. Then the data collectors were trained how to collect uncertainties. Then the survey was piloted. Next. So during the survey, we identified some challenges. We found the survey draft prepared was really very difficult to both to the data collectors and to the patient to comprehend and to run it smoothly. So we found that to have some improvement. So we were giving them training in whole by collecting them to come to Gondar. And we were also, during the piloting, going there and helping them to understand and to do it properly. And it was really difficult and challenging. You can see on the picture, our car was stuck in mud, and we required to have another car to pull out from that. Next slide. Then again, we came together with the steering committee member. We explained for them what we encountered. Then options were proposed to make it very simple rather than putting a lot of words. It was decided to make it very short, just to ask them, what do you think the causes of the problem you have? What do you think I mean, what ideas do you have in your mind related with the diagnosis of your problem? The same is true for the treatment as well as the impact. We didn't want to put any guiding content, guiding text in the survey. Just was open and just cause, diagnosis, treatment, and impact. Then we let them to speak what they have in their mind, and we decided to record what they are saying, because we found it is very difficult to create a good rapport with the for the data collectors with the patients. So we preferred just to record them, then transcribe and translate what the patient's carriers, and of course for the clinician we did the online survey. Basically, when I say clinician, these are obstetrician and gynecologists and urogynecologists living in a place where there is a good internet access. All the other health providers, especially those who are living in the rural setting where many of our participants are residing, we used the same technique as we used for the carrier and for the patients. Next slide. Then we collected data from 350 participants. Then this was discussed among the steering committee members and how we should go about the data we collected. Basically, these are video recorders. So direction was put how we transcribe and translate. The decision was to transcribe and to translate independently among two of the research associate and the lead. Then that was checked whether it is similar or not, and that was presented to the steering committee members. The steering committee members agreed that it is possible to proceed independently to work on the audio recorders without having checking in between three of us. So would you show us the file? So would you slide to the left side? So you can see how we transcribed. Basically, this is not a typical verbatim kind of transcription. Just it is just we picked only related their idea related with the cause or their uncertainty related with the diagnosis, the treatment, and the impact. So we talk some socio-demographic data like their address. You can see on the, of course, the first one you can see that is the serial number. Then the code for that special for that participant. Then the address. Then we have the age, the marital status, whether they are patient, carrier, or other clinician or other stakeholders, and if they are patient, whether their problem is genital prolapse or incontinence, or if the participant is a carrier, whether they carried for genital prolapse or incontinence, if the participant is a clinician, whether that clinician cared for patient with genital prolapse or incontinence, then the duration. Then after we have the calls. So we put, for example, for the first participant, she's a 45 years old patient who had genital prolapse for 10 years. And as a cause, she mentioned as it is, she said, it happened following delivery. It happened because I delivered at home. And she said also, this is because of the God will. Then the next column is about the diagnosis. So the same is true, like the treatment. Would you slide it further to the right? Then we have on the column L the diagnosis. On the column M we have the treatment. On the column N, and then we have the summary of all these four categories: the cause, the diagnosis, the treatment, and the impact. Then that was translated for every patient in English. And if there is any remark, we put that. For example, this woman, she said, I have never told this problem to anyone. So you can see. And she also raised this, we put as a remark because these ideas are not included in the as a cause, as a diagnosis, as a treatment, or as an impact. So next slide. Then we went to evidence checking after the summary. Next slide. So after evidence checking, we come up with unanswered questions. There were about 39 unanswered questions. Then we talk that back to the patients and to the steering committee members, and to then after to the patients. Next slide. Then it was really challenging to figure out how we can make the interim prioritization, because it's very difficult for our participants to comprehend really what it is. So we made a lot of consultation in addition to the steering committee member. Here you can see on the picture patient discussing the patients about how we should do the process. Then we collected about 160 data from 160 patients. Now it is on transcription and translation. Next. So we are now, we couldn't make the next step because of the ongoing conflict between the central government and the militia, and we don't know for how long it cannot be postponed. Next. So thank you for your attention. I'm happy to respond for any questions you have related with my presentation. Thank you very much.